Don't let my residents ever hear this.
It gets your mojo going.
It does. It's fun.
Probably be big rimping.
It's a safe place here. We're in the trust tree. I use inhaled sildenafil.
We're smoking like a round here.
Yes, we are.
Dangerously drinkable.
Actually, lucitropy is a thing.
Hey alcoholics, Jimmy here. A while back we sat down with John Ryan and recorded an episode, but unfortunately my audio was lost. But we're going to put it up anyways since Brian and John did most of the talking. John Ryan is a cardiologist at the University of Utah and runs a pulmonary hypertension clinic as well as performs research in the field. He is also a proud Irishman and was kind enough to sit down with Brian and I and share some of his knowledge. So here we are passing it on to you finally.
We've got another episode of Alcoholics Anonymous here, and we are joined by Dr. John Ryan. And so today we're going to be talking about a case, a patient I'd seen several months ago, and I think it might have some relevance to you in your practice, and I think you can definitely teach us a lot and help us kind of gain your perspective on some of the issues faced by patients with acute cor pulmonale in this case.
Sure, thanks for having me on.
We got a 42-year-old gentleman. He presents essentially with a complaint of dyspnea. He arrives tachycardic, and the initial report you get is that he's had 1 day of symptoms. He was found in his home by EMS with room air saturations about 60%. Had some sluggish mentation initially, but perked up on a face mask, and his saturations improved to about 80% on a non-rebreather. He was normotensive with a pressure about 110/70 and did have a very poor saturation on non-rebreather, heart rate about 120 to 130 throughout his initial evaluation. He was a big boy. At 42 years old, he had a BMI of about 60 to 65. He weighed about 425 pounds. He was about 5'9", 5'10", and was breathing pretty quickly, respiratory rate averaging around 30 breaths per minute, doing big pulls. Despite that, he was mentating pretty well when he got to the emergency department, was able to have brief conversations, couldn't really provide an inciting history for us. And he hadn't had any recent surgeries, no new immobilization, no family history of any coagulopathies, and no real predisposition in the past towards clotting. So we didn't know he had DVTs in the past, PEs, none of that was present. During his initial evaluation, I took a look at his lung fields and saw that there was no real evidence of pulmonary edema on ultrasound, and a portable chest x-ray confirmed that. He had fairly normal appearing interstitium with obviously an obese body habitus. And this was the first bedside image on his echo that I was able to obtain. And I guess we can just walk through this.
Yeah, so it's a tough case, and obviously a young man, as you said, and clearly not doing well. And there appears, based on what you've said so far, there appears to be an acute component, and you do wonder about a chronic component as well. And some of those hints of the chronic component then are here in this echo. This is a very good parasternal long-axis view of the heart. At the top of the image is the right ventricle, and which, in this view at least, appears bigger than the left ventricle, which is the chamber moving at the bottom of the view. Just to the, as you look at it, as you look at the screen, to the right of the left ventricle is the left atrium with the mitral valve opening and coming in. Trying to get a sense of left atrial size here, which is difficult in this view. But the most remarkable thing on these images is that the heart is going quite fast. There's no pericardial effusion, and the right ventricle is enlarged. And I think, and the left ventricle at least appears hyperdynamic in this view, and you don't, so that'll be obviously worth evaluating further, in particular with the apical four-chamber view. At the bottom of this image, there does appear to be a cylindrical structure or circular structure, which I'm wondering if is a dilated coronary sinus.
It may well be. And so this next image is a longitudinal subcostal view, and we're shooting through the inferior vena cava here. You can just see a touch of the cavoatrial junction, and the subcostal windows in this patient were difficult. But suffice to say, looking at this image, the IVC has a diameter of around 2 centimeters, slightly greater than 2 centimeters, measured at about a centimeter away from the cavoatrial junction. And during a course of respiration, it demonstrated less than 50% collapse. So
I think with both of these images, Brian and Jimmy, I think you get an appreciation that the right side of pressures are high, and now it's obviously worth figuring out why the right side of pressures are high. There probably is a chronic component, as I said, because that right ventricle is very dilated, and but with the enlarged right ventricle, the enlarged coronary sinus, and now a dilated IVC, looking at the right ventricle will be key.
So going forward past the IVC, I started looking for acute causes in this patient, and immediately at the bedside, there are a few things that I can do to correctly make a diagnosis of pulmonary embolism in somebody that presents with tachycardia, acute hypoxemia, and right heart failure. And so the first thing I did after getting some of those windows was take the curvilinear probe to go a little deeper into his soft tissue and take a look at his common femoral vein, because that was easily accessible. And on both sides, at the saphenous takeoff, the patient had fully compressible veins without evidence of DVT there. So that was a swing and a miss as an attempt to find something that I could immediately anticoagulate him for and make myself feel better about the overall situation.
Yeah, but really nicely done, and you're really trying to iron out the issues here, and quite quick, skillful imaging, consistent with your your emergency department fast protocol that you guys are doing. So this is important to do.
And so then the next thing I was hoping to find would be thrombus in transit, because we talk a lot about metrics in RV failure and identifying which patients have pulmonary emboli based on the way their RV is functioning. But really the only hard and fast way to make a diagnosis of PE on echo is to see the thrombus. And so for me, that means I'm going to do as complete of a right heart evaluation as I can with the transthoracic imaging. So this image is not perfect per se. It's a difficult image to interpret, and it can be difficult to obtain. But what we're looking at here is the right ventricular outflow tract from a parasternal approach with a variant of a long axis orientation. And you're seeing lung slide come in and obscure the window. But coming from the top down, we're looking at the RV outflow tract. The pulmonic valve is a wisp that's just barely visible on these images. And then extending down towards the bottom of the image, you can actually see the area around where the bifurcation of the pulmonary artery would occur. So this is a standard view in comprehensive echo. It's not something that we use a lot in a bedside echo in the emergency department. But if there were a thrombus present in the proximal PA, there's a chance that you could see it from this view.
Yeah, the other thing that you see here, Brian, is that this pulmonary artery looks enlarged and this right ventricular outflow tract looks enlarged. So again, going into the issue of chronicity of this disease process. And this is also the view, however, where you can get pulmonary artery acceleration time or right ventricular outflow tract acceleration time to, again, give some sort of estimate of pulmonary vascular resistance, which in the setting of pulmonary hypertension, in particular in the emergency department in pulmonary hypertension, folks oftentimes use this 60-60 rule, which I suspect we'll come to later, which is a reference to the pulmonary artery acceleration time.
And so the correlate to the RV outflow view would, of course, be an RV inflow view. Now, you could obtain both of these in a parasternal short axis, and I think we have at least a still image of that from this patient. But you can tell with his tachypnea, there's some respiratory variation throughout the cardiac cycle, but what we're seeing here again at the top of the screen, right ventricle, tricuspid valve, and then deep to that going towards the bottom of the screen, you can see that coronary sinus take off. The eustachian valve is juxtaposed between that and the inferior vena cava. And again, you can look for thrombus in transit here. And this is also the view where you'd want to be evaluating tricuspid regurgitation and trying to determine exactly how high are these pressures that we're facing on the right side.
Yeah. I would add on the three views that you've shown us, the parasternal long axis view, the right ventricular outflow view, and the right ventricular inflow view, the three of them are useful for looking at right ventricular hypertrophy as well. Now, and on these views at least, there hasn't been evidence of right ventricular hypertrophy. Some folks have advocated that this suggests that there's a lack of chronicity, and they base the fact that the absence of right ventricular hypertrophy can be associated with a more acute process. However, I disagree with that, and I think if you go back to your left ventricular failure, which we're all very comfortable with, so when you have your burnt out hypertensive left ventricle, it eventually becomes thinned. You have your left ventricular hypertrophy from hypertension, and then towards the end stage it gets thinned out. And the same thing can happen in the right ventricle, that you get a compensatory right ventricular hypertrophy, but over time, if the disease processes continue, eventually it thins out and and burns out just the same way as with LV failure. And that may be what we're seeing here, or at least the absence of right ventricular hypertrophy does not infer that this is not a chronic process.
So at this point, I didn't feel like I had enough information maybe to act on, and I wanted more information, but the patient had an elevated creatinine. The last value we'd had for them was 1.3, and on an ISTAT, creatinine of 2.7 makes it difficult then to obtain any contrasted imaging. He was actually too big to scan. He wouldn't fit in the CT scanner. I placed him on CPAP to try to recruit some more oxygenation, which has some downsides to it, and improved his saturations to about 84%. He continued to mentate well at this point, and his pressure stayed fine. And because I was at an outside facility, I was looking at transporting him for appropriate ICU capabilities, but he was too big to fly. So now we're looking at ground transport on a patient that is definitely not stable. So this was, this outside facility was in Rock Springs, Wyoming, and the patient, so it's approximately 3 to 4 hours via ground transport, and you can shave that in half or even cut it by a third if you have air transport available. So going forward, what would you do at this point? Would you lyse this patient, say this acute presentation is definitely a PE, he's in a submassive category, there's evidence that we can improve his long-term outcomes if we lyse him? Would you heparinize him in the stance that it's kind of a middle ground, you can turn the heparin off, intubate him to secure his airway for transport, which is its own topic, which is rife with difficulties, or obtain more echo images.
So I think you can obtain more echo images, I think, to try and iron this out some more. And clearly, as I said, there's a component of chronic pulmonary hypertension here, whether or not that's due to chronic obstructive sleep apnea, obesity, hypoventilation syndrome, diastolic dysfunction, chronic thromboembolic pulmonary hypertension, and how much then is acute on top of it. So I think in this scenario, what I would like to see is your evaluation with further echo imaging.
Moving forward, this takes us into kind of a more advanced realm of evaluating for right heart dysfunction, and there are a variety of metrics that we have at our disposal for this. These are just a few of them listed here. So you have TAPSE and S prime, which are essentially analogous measures for comparing annular motion around the tricuspid valve. Pulmonary artery acceleration time, which you'd mentioned earlier, and its correlative feature, the 60-60 sign, and its use in the emergency department. And then RV chamber quantification. And you already talked a little bit about using RV free wall measurements to determine chronicity and some of the pitfalls, I guess, that are associated with that. And so we can talk about each of these in turn.
Yeah, and I actually would add in a left atrial assessment as well, trying to left atrial size in the setting of diastolic dysfunction and kind of adding to the chronicity.
And so as much as possible, I've tried to incorporate images from that case. The patient, because of their respiratory difficulties, had incredibly difficult apical windows, both in association with their body habitus and tachypnea. And so those were not quality images. This image here on the bottom right is an M mode image with the cursor placed through the tricuspid annulus. However, this is done from a parasternal approach, and I wouldn't advocate doing that. There's no data to validate it, but at this point, I was looking for any information I could obtain and was curious what sort of annular motion I would see. And the image to the left is obviously a normal apical four-chamber projection, which is where you would typically obtain your TAPSE measurement. You would put that cursor down through the RV free wall along the level of the annulus and see sort of a sinusoidal motion of the annulus moving through systole and diastole. And by measuring the peak displacement of the annulus, you get a sense of gross systolic function. If you look at the image on the right, you can see that it's roughly about a centimeter of displacement. But again, this is from a parasternal approach.
Yeah. So the tricuspid annular plane systolic excursion is a really useful measure of right ventricular function, and is also a prognostic measure of right ventricular function. And the right ventricle compresses kind of like a music box. It goes up and down, as opposed to the left ventricle, which comes in and out. And what you're referring to here and evaluating here is how well the right ventricle is moving up and down in the contraction of the right ventricle. It's difficult. It can be difficult to get, and as you described the limitations that you had here, but when it is obtained, it is very useful. The typical cutoff that we use is 1.6 centimeters. That the TAPSE should be in normal folks. So in those of us here in this room, the tricuspid annular plane systolic excursion should be greater than 1.6 centimeters. And if it's less than 1.6 centimeters, that is a sign of right ventricular failure and a prognostic indicator of poor outcomes. The prognostic indication of poor outcomes is representative across pulmonary arterial hypertension, pulmonary hypertension secondary to left-sided heart disease, so secondary to diastolic dysfunction, and probably also pulmonary hypertension secondary to chronic hypoxic lung disease, or cor pulmonale, as many people refer to it as. More recently, the TAPSE has been shown to be useful in some cases of pulmonary embolism, but as we might go on to later, the hypokinesis that you get with pulmonary embolism and the effects of an acute pulmonary embolism on the right ventricle can have an impact on TAPSE that can make it a little less reliable. One of the things as well is that TAPSE also does depend, when you look at this on MRI and when you do a TAPSE measurement on MRI, a lot of the right ventricular function actually does depend on left ventricular function. So if you look at actually the cardiac output of the right ventricle, for example, 1/3 of the cardiac output is determined by left ventricular function. And so therefore some of this TAPSE can be impacted by what the left ventricle is actually doing. So that can result in some variation, and why, again, it doesn't end up being an absolute number, and because none of this is absolute, right? And especially when you're dealing with BMIs of 60, the inferences and the assumptions that we make for folks who have lean BMIs of 20 to 30 really oftentimes go out the window with these BMIs of 60, which makes it very, very challenging. But it's a very useful marker, and is something that you really should incorporate into your package and into your armamentarium when you're imaging the right ventricle.
And so now we get to PAAT. And on the left-hand side here, you can see an image that actually shows that translation from a parasternal long axis view to an RVOT view. And it happens pretty quickly. But you'll see that aortic root exit the image and be replaced and positioned by the pulmonic valve. And below that will be the extension of the pulmonary artery. It might be difficult to really tease that out, but just take a second to look at that. And then what you see on the right is a combination of the actual images I obtained attempting to get PAAT on this patient with a small added Photoshop component of a really nice flow profile with the open envelope that you'd want to see when obtaining this image. If my images had been better, I would have felt a bit more confident with it. But regardless, I was working with what I had, and as you can see on the right-hand image, so what we have is a frozen image, and you're seeing downward deflections of velocity time integrals. These are obtained with a pulse gate, and the pulse gate is placed just below the level of the pulmonic valve on an RVOT image. And what you're hoping to see is an empty flow profile that demonstrates laminar flow as blood's leaving the right ventricle. And you want to measure the time that it takes from the onset of flow to the peak velocity of flow. And the shorter that time is, the more that it is associated with increased pulmonary vascular resistance or pulmonary hypertension. And there are a variety of physical reasons why this has been proposed, but it can get quite complex, I think, when you try to break this down and sort of cognitively address that.
So I think this is a really important measure, and we use it in our pulmonary vascular program. We use it all the time, both prognostically as well as you said, an estimation of pulmonary vascular resistance. So there are a couple of key components to this. First is conceptually. So conceptually, going into the pulmonary vasculature, it appears that you have flow going in at a very high pressure, and that's akin to a fire hydrant, basically, or water coming out from a fire hose. It's coming out at very high pressures, and it accelerates very quickly, and it reaches that peak acceleration very quickly. This is in comparison to your garden hose, where the flow comes out at a much lower pressure. So that's conceptually one way that I like to at least think of it. The second issue, going back to our fire hose analogy, is that when you put a fire hose against a wall, so something with a large amount of resistance, it'll come back and splash you in the face. And so when you're faced with a lot of resistance, a lot of the blood flow can actually come back and result in a sudden cessation of blood flow and of acceleration of that blood flow. And that's referred to as notching. And what you see is that the acceleration peaks up, and then all of a sudden there's a cessation in acceleration, or a notching. And that notching by a lot of folks has been shown to be equivalent of having a PVR of greater than 3. And when we talk about pulmonary vascular disease and pulmonary vascular remodeling and chronic pulmonary vascular remodeling, you're looking for a pulmonary vascular resistance that's greater than 3. So in that regard, the notching can be quite useful. Binary is a binary feature when it is present. When it's absent, you don't know if it's absent because you haven't been able to line up your images properly, or because the PVR is less than 3. So that short acceleration time then is useful, and people have different cutoffs. Probably a cutoff of less than 80 milliseconds is pretty indicative of elevated pulmonary artery pressures. You and me, our pulmonary artery acceleration time, so the amount of time it would take for our pulmonary vasculature to reach a peak velocity would probably be about 150 milliseconds. So if you have less than 80 milliseconds, that's probably equivalent with elevated pulmonary artery pressures. And then the shorter it gets, namely the shorter amount of time it takes for it to reach its maximum velocity, the higher the pulmonary artery pressures. So that's a useful measurement that we use in our pulmonary hypertension clinic very frequently. It does require, as you rightly pointed out, it does require to line up that pulse wave quite well. It does require to have parabolic flow, and which is represented by having a thickness on the outside and a darkness in the middle. So I guess for American audience, kind of the opposite to an Oreo, and trying to get that view so that you have that, you know that you're lined up in parabolic flow, and but again, that can be very challenging to do.
All right, Echoholics, we're going to stop there for this episode and pick up next time to see what happens with Brian's difficult patient and to continue our deep dive into pulmonary hypertension physiology with expert John Ryan. Stay tuned because we have a lot of other content coming your way. I predict it's going to be a very good year for Echoholism. See you next time.